So after we've calculated the QRS duration, we move to the QT interval. And the QT interval begins at the start of the Q wave and ends at the end of the T wave as it meets the isoelectric line. When you calculate the QT, there's actually a shortcut to say quickly whether the QT is normal or not. If you look at the R2R interval, or if you take two QRS complexes, you identify the halfway mark. If the T wave ends before this mark, then we can assume that the QT interval is normal. In other circumstances, we may want to calculate the QT interval properly, especially if we assume that it's prolonged. What we do is we use the Bazet formula, which you can find on MedCalc, and it is the QT interval divided by the square of the R2R interval. The most important thing to remember is that you should use the Bazet formula only when the rhythm is regular and when the rate is between 60 and 100, because it will underestimate the QTC in bradycardia and it will overestimate the QTC in tachycardia. The thresholds for what is a long QTC vary, but 440 milliseconds in males and 460 milliseconds in females will give you a rough guide. But a QTC of 500 or more, and that will dramatically increase your risk of ventricular arrhythmias. The risk of a long QT is both VF, ventricular fibrillation, and also a type of polymorphic ventricular tachycardia called torsade de Pointes. There's many causes of a long QT or a prolonged QT interval, but the most common is acquired. You can also have genetic conditions called the long QT syndromes, but they're relatively rare. Some of the acquired causes would be medications and also electrolyte abnormalities. So electrolytes, we're thinking low potassium, low calcium, low magnesium. And medications, we'd be thinking antipsychotics, antiarrhythmics, antibiotics, etc. The main mechanism of how the medications cause it is they block the potassium channels. And that's why class 3 of the antiarrhythmics like Ibutilide and Sotalol, they cause a substantial increase in the QTC.